So our speakers today, I'm really happy to introduce Dr. Benjamin Marcus, Dr. Jay Calvert, Dr. Jeff Marcus, Dr. Hesham Saleh, and Dr. Pietro Palma. So we have an international group of surgeons who are well known for their work, and I'm very thankful that they've taken the time to share with us their experience. Next week, just as a prelude, we're going to be talking about revision rhinoplasty. So I'm going to just do a little brief introduction into what we're talking about here for the folks in the audience who may be beginners at this. When we're talking about preservation methods and the traditional resective methods in dorsal reduction. And basically, there have been in the past 100 years, two major schools of thought for reducing dorsal humps. Profileplasty is one of the most common things we do in rhinoplasty. The Joseph technique, and Jacques Joseph is one of the fathers of facial plastic surgery and plastic surgery, is essentially resective, taking the top of the nose and reducing it by cutting the top. The caudal method, which actually predates caudal, so it goes back almost to the time of Joseph, actually beyond the time of Joseph, is to actually take the dorsum and push it in. And I'm just going to show that real briefly. So in the caudal method, we're talking about cutting around the base of the bony osteocartilaginous vault and pushing it into the nose. This is the septal work that's done. And in a cadaver dissection, it looks something like this. Let me go back one. Here we go. So you push the whole thing in like so. Now, we talked about this last week, and I'm not going to spend a lot of time on it, but I want to compare and contrast the theory of pushing in the nose versus the Joseph method, which is a resective dorsal reduction method. And in this, the steps are essentially some variation, as you'll see today, of cutting the cartilage, shaving the bone, and then performing osteotomies to close the so-called open roof, and then performing some sort of mid-vault reconstruction. And schematically, it means something like this. It means taking the top off here, and you create, as you can see, a flat area at the top that needs to be then closed, as it were, to get a normal contour. So in this case, we perform osteotomies, which we'll be talking about today, and then we close the open roof. And our speakers are also going to be talking about mid-vault reconstruction methods. So those are some of the topics we're going to discuss today. And if you look at this and compare it to the other method, in the end, you are hoping to get the same result, which is a nice-looking dorsal contour that's in the lower position. So this is the method I've been using for many years, and this is an example of somebody whose surgery was performed 6 or 7 years ago. He's a great candidate for this, and I used some of the methods which are going to be discussed today. Joseph method reduction, component reduction, mid-vault reconstruction with autospreader grafts and osteotomies. And in the end, this is a 6-year follow-up. He has, I think, a pretty good result. We're not going to talk about anything done with the tip, but he has a nice profile, and it's really held up over time. This is another candidate which would, really not be a good person to try a let-down or push-down caudal operation on a very large hump. And in this case, you can still make a dramatic difference. It's very challenging, even with the Joseph method, to do this much resection and closure. The rhinoplasty surgeons out there will know that, because you end up with such a large open roof. In this case, I used the ultrasonic piezo rasp to do the osteotomies, but mid-vault reconstruction required extensive spreader grafting, autospreader grafting, and in the end, this is what it looked like on the operating table. And all that skin has to shrink down to this new size, and here she is a year out with an adequate, very nice result, in fact, I think. And she's quite happy. So these are just examples that the Joseph method is far from dead, and I think it's something that we should continue to discuss and refine. And I'm really excited that today our speakers are going to talk about it. This is, again, another thing that I do in my patients now is I always show their SCHNOZ scores and look at their outcome measures, and this is that patient preoperatively. Function are the top 4 and the bottom 6 are cosmetic, and then postoperatively, a year out, she's doing much better on all counts. Whenever I can, I try to show this type of data. The first patient, the SCHNOZ questionnaire wasn't around yet, so I couldn't show it. So I think this is something that's very useful too. So in my hands, I do resective dorsal reduction via the Joseph technique often still for kyphotic bony humps, very deep radix, twisted noses, large humps, and preservation I like to do in people with shorter nasal bones, gentle sloping humps who have pre-existing nice dorsal aesthetic lines that you want to preserve. So I think there's a place for both. And today we're going to be talking about the Joseph method. So with that, I'm going to turn it over and stop sharing. I think our first speaker is going to be Dr. Ben Marcus. I want to welcome Ben from the University of Wisconsin. Ben, I'm going to turn it over and have you just start sharing screen now.
Great. All right. Can everyone hear and see me okay?
Yes.
Great. Well, first off, I want to thank Dr. Most for inviting me here. I'm giving the lead off talk, and really the focus of my discussion today is going to be how the Joseph reduction still has a place, especially when you're combining aesthetics and function. In my practice in a university setting, I still do a fair amount of cosmetic rhinoplasty, but I do an extremely large amount of functional rhinoplasty. And so for me, one of the key concerns, especially when tackling a dorsal hump, is what method is going to give me the best long-term results? How am I going to prevent these patients as much as possible from having a long-term complication? I have no disclosures. So my talk is not against preservation. Like Dr. Most, I have experimented with preservation rhinoplasty. I've attended many meetings where I think the results are fantastic. But I'm going to argue why the Joseph method is still valid and in many cases could be a preferred method because of the degree of control that it gives us when reconstructing the patient. Because really, at the end of the day, it is all about time. Rhinoplasty is the one surgery where we truly have 4 dimensions of healing. And if we're not thinking 5 years, 10 years down the road, we're going to have failures. And I can speak from being in practice now almost 15 years and being in a place where there's not a huge number of rhinoplasty surgeons. I have the great honor of seeing my own complications back. And one of the things that has pushed me to continue refining this Joseph method is the ability to make sure that those changes last through the test of time. 2 patients. This is a patient that has some soft, natural curves to her nose. She's got the correct highlight and shadows when you look at her brow tip aesthetic line and her tip shape. And she's got a good long-term functional outcome. This is a 24-month follow-up. If we contrast that with the following patient, where we look at those same areas, all you have to do when you're looking at this patient on the right is look at her eyes. And you can tell she's not happy. This is a patient who's come in seeking revision rhinoplasty. What's occurred in the second patient is collapse and distortion of the midvault, incorrect brow tip aesthetic lines, and inadequate support of the tip. She did have a resective rhinoplasty, but the key thing is that the difference between these 2 patients, the one on the left and the one on the right, is the one on the left had adequate reconstruction and the one on the right did not. So what's the best way to build? Well, in some ways, preservation rhinoplasty is like the game of Jenga. You're trying to take out small pieces from the nose and hope that things kind of fall into the right place. And if you're an expert at doing this, it works great and the results can be very good. I prefer to think like an architect, and I want to make sure that rather than removing precise pieces and hoping that my outcome turns out the way that I've planned, I want to build it from the ground up. So I want a strong framework that's going to give the best possible long-term result. So let's start with the case presentation. This is a 16-year-old female. This is from quite some time ago, but it's with the purpose of showing long-term results. She presents in a very typical fashion for my practice, which she has some breathing concerns, but she also dislikes her dorsal profile. This is back in 2009. When we examine her, we see that she's got, from the frontal view, a little bit of pinching at her mid-vault, a slightly under-rotated tip. She's got a very large bony and cartilaginous dorsal hump. And as previously mentioned, just slight under-rotation of the tip. So the key findings when we look at her are that she has this large bony and cartilaginous hump. She has a narrow mid-vault and she has a very modest deviation of her septum and some moderate inferior turbinate hypertrophy. She also has slight under rotation and slight decrease in her tip support. So the operative plan for her is to use an open approach, and again, this is circa 2009, Joseph reduction with extended spreader grafts that are articulated to a caudal septal extension graft. And then, of course, septoplasty and turbinate reduction. Now, what you can see here when we look at this picture is the proposed outcome for her. And this was using two-dimensional patient imaging back in 2009. And it shows a moderate dorsal hump reduction and improvement in her tip position and rotation. Here's just sort of a quick intraoperative video of this traditional Joseph component resection. And here in this 60-second video, you'll see that using sharp reduction, both the upper lats and the septum are removed in component. Nowadays, and we'll be talking about this later, we very well might have spared the upper lats so that we could do turn-in spreader flaps. But this is an example of the traditional component resection. So then we take a 7mm chisel, and these chisels are so extremely sharp that a lot of times we can just push that chisel right up to the bones, and with a few quick taps, remove the bony component as well. And then you'll see here in just a moment, quick tap, tap, and the whole combined resection occurs. Now, is this a destructive technique? Absolutely. So there's no arguing that traditional Joseph reduction destabilizes the nose, but it's not a destructive technique if the mid-vault is properly rebuilt. And so I don't think you can really discuss the modern Joseph technique without discussing modern reconstruction. And so let's look at this patient, look at her outcomes. And so here's the patient from the front view, 26 months post-op. This is her earlier follow-up. Good dorsal reduction, good tip position, and again, this is 26 months out. And from the oblique view. She's happy, she's breathing better. This is before we used the nose or the schnoz score, but a good functional outcome for her. What's key, and what I think is the takeaway from this case, is that with extended follow-up, things continue to be stable for her. So here's that same patient at 26 months post-op and 8 years post-op. She still has very good dorsal contour, her tip position has not changed, and she has excellent support. Same thing from the oblique view, 8 years. Her face has changed a lot over 8 years, but her nose has not. And then from the frontal view. So what's my algorithm? Well, for me, if I have a dorsal hump, I basically am going to split these into a moderate or significant dorsal. If it's moderate, I, like Sam, enjoy using the piezoelectric device and can take those down. When it's significant, I'll perform sharp reduction. But the key thing is we don't just do spreader grafts, we do a true reconstruction of the mid-vault. So it goes beyond just achieving the aesthetic goal. And of course, stabilizing the mid-vault after Joseph reduction is key for that. But we can also customize it for each patient. So in this particular case, we're seeing a male patient, there's asymmetric spreader grafts placed, and the key thing is that with the reconstruction of the mid-vault, you need to make it in continuity with the tip supporting mechanism. And by achieving that, you will have a truly stable platform for the nose that can last for many, many years and gives you the maximum possible strength. And the proof is really in the numbers. So when we looked at our own UW data, which we are in the process of publishing, we looked at 760 patients from 2014 to 2019. 150 of those underwent dorsal reductions in the Joseph fashion. But the average nose score, because most of these, again, were patients that had functional concerns, dropped by 45 points. And it's more than just clinical data. Some of our most esteemed panelists here, including Dr. Most, have written on this. And Dr. Most did a really fascinating cadaver study just recently and showed that when you compared the preservation techniques, the traditional Joseph techniques, plus reconstruction, the cross-sectional area of the nasal valve and the patency of the nasal valve appeared to be not affected by a properly performed Joseph reduction. So let's look at one more long-term case. This is a case actually somewhat similar to what Sam had showed, a very wide and broad dorsum, underwent Joseph reduction, extended spreader graft placement to her tip supporting mechanism. And this is a 1-year follow-up, profile view, stable. But most importantly, 9-year follow-up. And when we look at her from the side, in that 9-year period, very little change, very stable over time. So in conclusions, the Joseph technique is actually my preferred technique for dorsal reduction. It is a deconstruction, and it does require reconstruction. But when that reconstruction is done in such a way that it's architecturally sound, it gives us, the surgeons, I believe, maximum control over form and function, and the long-term results are very durable. So thank you very much.
Thank you very much, Ben. I have a few questions and comments I'm going to ask about auto spreader flaps and spreader flaps. So I'm going to wait until Jeff and everyone has spoken, and maybe towards the end we'll do a little bit of discussion about that, because I know other people are going to talk about that a little bit. But one question I have for you, and I might ask the other panelists as we go along, so maybe think about this, and Ben, you haven't had a chance to think about this, I'm putting you on the spot, is what is or was your biggest challenge in doing hump reduction with the resective technique, with this technique? I mean, what do you find is the biggest challenge? I'll tell you what one of the biggest challenges is for me. I'll start it off, give you a chance to think about it. One of the biggest challenges is when you take a symmetric nose and they have a high septal deviation, and you take the dorsum off and you see that the septum is off center. Okay, so when you do osteotomies, naturally one's going to want to fall in more than the other. But you want to close this vault, so you don't want to completely keep it up there. So you do all sorts of spreader grafting. People talk about releasing the septum off the skull base, or, you know. So I still find that it's an imperfect way, and often that's when you can create an asymmetry when one didn't exist before. And it's one of those things that you just bang your head against the wall when it happens. It's something, you know, I do a lot of revision rhinoplasty. When I see those patients like that, I can guess probably what happened in surgery, and there's nothing that the, you know, I never point the finger when I'm doing these revisions, because I know these things can happen. But what do you find is one of the big challenges that you had or do have when you do this type of surgery?
Yeah, thanks, Sam. So for me, I think there are many challenges, but the one that comes to mind immediately is complete destabilization of the nose. So again, a lot of my patients have combined functional anesthetic problems. They might have a crooked nose, they might have had an injury. And so combining a Joseph reduction with complete osteotomies, where everything is mobilized, is really one of the big danger points. And you know, I also work with residents all the time. And so, you know, the sort of double jeopardy of doing so much that the nose becomes completely destabilized, sort of flail. And so one of the things that has helped me greatly is, although I'm still a very strong believer in the Joseph reduction, by using the piezoelectric, for instance, for osteotomies, and limiting the amount of lateral destruction that occurs, I've been able to reduce the incidence, not completely eliminate, but reduce the incidence of patients' noses becoming overly destabilized.
Yeah, great. That's true. That is a big challenge, and I have liked using the piezo. Okay, so any questions or comments from the other panelists before we turn it over to Jay? Okay, all right. Thanks, Ben. So our next speaker is Dr. Jay Calvert from Southern California in Beverly Hills, and I'm really happy to have Jay here. Jay is also currently the president of the Rhinoplasty Society. Welcome, Jay, and I'm going to turn over the Zoom to you now.
All right, let me share this, see if this works. Oops, let's get back here. All right, is that, you can see all that?
Yes.
Let me get to, there we go. All right. You can hear me okay?
Yes.
All right, here we go. So this is sharing. All right, so this is good. I like the Joseph Hump reduction. I use it a lot. It's my preferred technique. I have now done a couple of preservation rhinoplasties, and I think it's a good technique also. But the indications for me on preservation are few and far between. These are my disclosures. And again, we've talked about this. You can screenshot these for yourself, but my patients definitely have not consented for distribution of their photographs, which means that they can't be stolen and put up on other websites for personal use. So feel free to screenshot these cases. They're actually on my website and on my Instagram, so that's not a big deal. This is a patient that came to me for dorsal hump reduction. And at first glance, I know a lot of people would look at this and say, this is a great candidate for a preservation rhinoplasty. And I think that that's possible. You can do some tip work. You can probably drop this down in some way, shape, form, or whatever, and you can trim the septum, maybe support it with a strut through a closed approach. But for me, I have a hard time with the multiple factors that have to occur to make this nose look amazing. It's very hard for me to just say, yeah, put this up a little and I'll push this down and things are going to be great. The problem I have in approaching it that way is that I don't want to leave anything to chance. I want precision. I want to know that I've done everything I can to get an A+ result. And I have revised over 15 preservation rhinoplasties at this point. And the biggest problem has been residual hump. That's not surprising. It's not incredible that with a preservation rhinoplasty, you're going to get recurrence of the hump. So I get very concerned when I'm revising these cases that there is going to be a residual hump. So for me, sorry, let's go to this next slide. If you look here at her, sorry, this thing's doing a little bit wacky stuff here. If you look at her hump, it looks like you could just push this down. And I'd like to hear from the other panelists who would do this as a preservation rhinoplasty versus doing the Joseph method. And it'd be great to poll the audience if you can. Maybe you guys, Sam, you could poll the audience who would do this case as a preservation case. So the droopy tip for me, the hanging columella, the amount of tip work, the balance that I need to achieve between the bridge and the tip tells me I have to do the Joseph method, which isn't a big deal. And I don't care how you cut bones or if you shave them down or if you use, I like power tools. I don't have the piezoelectric one. You can use it. I think it's great. But you can, however you want to get the hump down, you can do it your way. So for me, what I want to do is remove this hump, infracture the nasal bones, close the open roof, which is the Joseph hump reduction. I don't know if you need to close the open roof. I need to narrow the bones. I typically fill the open roof with various things. I use spreader flaps. I use spreader grafts. I use little tiny, grafts that I suture to the remnants of the septum. In the open roof, I'm all about building the nose. I'm all about contouring and making a result that is permanent. And everybody says, well, you can put fascia over it, whatever. I looked at my recent use of deep temporalis fascia and diced cartilage grafts in primary rhinoplasty. It's under 1 or 2%. I use them much more in burned out saddle noses and secondary cases. So I don't typically use camouflage grafts in primary rhinoplasty. And I only do about 5% of my primaries closed. 95% of my primary rhinoplasties are open rhinoplasties. In my secondaries, in my revision rhinoplasties, it's 70% are open, 30% are done endonasally. So what is the advantage of doing an incremental reduction? The advantage is that it's precise, versatile. You can change on a fly. High septal deviations to me are the biggest problem for preservation rhinoplasty. And I think if you want control and you have a high septal deviation, I'm not saying you can't do it with a preservation technique. I've thought about it. I could definitely do it, but I want precision and I want it to be versatile and flexible. And when I do get my tip in position, I want to have the ability to adjust and to change things on the bridge of the nose and really get an amazing aesthetic and functional result. This is a very customizable approach. It's repeatable and predictable. And that's what I need. I need things to be predictable for my patients. So here's let's see if we can get this to work here. If you look at this, this would be a typical open look at the dorsum of the nose, and you're looking down on everything. You can see, you know, I've released the lower lateral cartilages. This, to me, you've got a clean shot at everything. You know, how can you really say that this is problematic? Now you can reduce the hump. You can adjust the bones. You can add grafts, spreader grafts. You can use spreader flaps. You can use flaps and spreader grafts together. You could, you know, look at multiple levels of osteotomies. There's so much that you can see here. Whereas if you're going to do a endonasal preservation technique, you need the perfect candidate. And so this has been hard for me to find those patients. So I'm just going to speed through this a little bit to the key parts. Here I'm just rasping the dorsum. You know, nothing big. This isn't fancy. There's nothing really difficult about this. Again, some people love to use the piezoelectric. You know, go for it. It's great. I typically use a burr. Here you can see I've taken the bones down, and now we're looking straight down on the septum. I take a knife and I do my dorsal reduction. This is usually, you know, obviously I measure everything out. It's not in this video, but there's, you know, boom, that's off. There's your dorsal reduction. And now you have total control. You're looking at spreader flaps. You can look at whatever you want. You sit, and this is what I do, is this is my view, because I take a knee and I start looking at the profile and what needs to happen now to contour the bridge. And so this gives you loads of flexibility. Now you can decide, am I going to use spreader flaps? Am I going to use spreader grafts? You know, how does this look? Do I like it? Do I hate it? Do I want to add to it? Do I want to, you know, take a little bit more down? You have so much flexibility in dorsal contouring that it's hard for me to give this, you know, away on a case where I think if I'm going to have any trouble whatsoever in getting that dorsal line correct, then I want to do it this way, because this is just straightforward to me. It's like you're looking right at, you got a clean shot. You know, rhinoplasty is a lot like golf. Anybody who plays golf, you know, the ball is sitting right there on a tee. All you got to do is hit it straight. And this is the same thing. The nose isn't moving. You know, you don't have people shooting at you while you're doing this. Nobody's trying to tackle you. Like, it's right there in front of you. So why make it hard and leave guesswork in it? So I'll move on from here. You can see I'm putting in some spreader flaps and some grafts. And let's just go to the next slide here, if it'll go forward. There we go. So yeah, there you can see, once again, that's your view. And if you look, this is her after photo. So she's got, you know, a very natural look to her nose. She's got, you know, a much better looking nose. The tip has got better architecture to it because we were open. We could narrow it. I could combine it with, you know, the plastic, get things to look a little bit more like they belong there together. And, you know, you just have, I think you have a clean shot to make her nose a really straightforward rhinoplasty. And again, this is how I do it. I like this Joseph method. It is my preferred approach. I've been looking for the preservations. I've done a couple now, and they're interesting. It definitely allows for balance in the nose with the Joseph, whereas you're sort of, with the preservation approach, you kind of got to take what you have and work with it. And that gives you really need the perfect candidate, in my estimation. And with the Joseph method, the controls built into the procedure. You get excellent results. They're repeatable, and it works for me. If you want to hear more about it, again, on my podcast, Dr. Ravello and I talk about rhinoplasty an awful lot. Our next one is going to be on hump reductions, but it's on Apple Podcasts, and we have a couple of episodes that deal with this and how to contour the bridge and blend it to the tip. And that's all for me.
Thanks, Jay. Really appreciate your perspective and your experience. So you brought up something interesting. So before I get to that, I want to ask you this: what is your biggest challenge when you do what was or is your biggest challenge? What is the most challenging type of nose, for example, that you treat for hump reduction?
I think the toughest one is where you have a high septal deviation. I think when you have a septal problem and a hump, like all hell can break loose when you're bringing that hump down, because you don't really know. There are a couple of things that happen when you do a septoplasty and you reduce the hump. The memory in the cartilage that you're going to see in your L strut gets a little unpredictable. And so when that happens and you start to see new things happening with the septum, it's very often that I will actually just divide the septum at some point through the L strut and repair it, because I want to take that memory out of it that's going to cause deviations of the nose down the road. And I want to really strut things together and have it be, my decision about how that L strut's going to behave, rather than like hoping there's going to be, good news for me in 5 years. So I find those high septal deviations to be a cause for alert, and to be very flexible intraoperatively with how to reconstruct the middle vault and really the upper vault.
Yeah, I mean, like I said, I agree with you. I think that's one of the biggest things. So when you said you divide the septum to try to fix that, do you mean like high up at the rhinion, just take it off and reset, or are you talking about somewhere else?
No, somewhere in the mid body.
Okay.
You look where you see that bending happening. You get your spreader grafts in place. Make sure they're really strong and get the whole things together, and then just take the memory out of that bend by dividing through that L strut, and you've got it all set up, and slap it back together with your PDS sutures, and life is good. But again, you have to make sure that you have good cartilage to do that. Obviously, when you have rib cartilage, it's a no-brainer. You can really, tell the nose how it's going to be over time with rib cartilage. But with these primaries, I've done probably 6 or 7 pretty difficult primaries in the last week, and a couple of them I posted on Instagram. They were hard because the septum was so wacky, and if you're not looking for it, that's when you get burned, and you have to be on high alert. And I think with preservation, there might be actually some part of me says that the high septal deviation in a preservation situation might actually be easier to manage, because you're just masking it by dropping the whole thing down. So
I agree with you. That's one thing I found, which is nice.
Yeah, and the one that I did this month was that way, and I just said, you know what, I'm just going to take that part out and drop the whole thing on top of it. And I mean, I'll keep you posted. I think it looks great now, but I don't know what it's going to be in a year. So
yeah. How do you like to? This is a question for everybody that's popped up that somebody asked. By the way, for everyone who's watching, thank you for watching. If you have questions about dorsal reduction and what we're talking about here today, that's great. We're not going to get into septal extension grafts and all that kind of stuff necessarily in this panel unless there's time at the end. So ask questions about sort of more of the dorsal reduction material. So the question is, how do you like to treat a really wide nose? For everybody, anybody wants to answer, that's great.
Well, the wide nose, I think you have to kind of look at it and say, does this person need any sort of medial oblique osteotomies, or can it really be handled by reduction and mobilization of the bones? Because I mean, why is it wide is really the question. That diagnostic approach to the wide nose is really key, and you have to spend some time understanding it. I rarely need medial oblique osteotomies. It's really interesting. Half the time I go in thinking, I'm going to have to cut these bones laterally and I'm going to need medial obliques. But it's probably only about a third of the time that I think I'm going to need them that I need them. Half the time I can just cut the bones, move them in, get some really good bone cuts up top and, at the frontal bone, and they move. So it's, again, be on high alert, but don't over operate the native bones.
What I found, and I'll just answer this before, I'll go Hesham and Jeff. I think you guys want to talk. Why don't you guys go first?
Yeah, I agree with you, because I don't find that I need medial oblique osteotomies most of the time. But if I have a wide nose with no hump, then it's a different situation. Again, then I'll do intermediate osteotomies as well as the medial oblique and the lateral. But that's usually a rare situation, really. So in the majority of the time, I will just do the dehumping lateral osteotomies. And if I really need to narrow it a little bit more, I do transverse osteotomies. I'll show that in my talk, mid-transverse osteotomies. So that's my my view on this.
Jeff?
Yeah, I think, thanks, Sam. Jay made a good point. And, you know, with preservation, you're sort of dealing with the hand, playing the hand you're dealt. You know, you have to analyze your situation, and hopefully you've chosen the right patient. And then, you know, you'd be able to, you could manage it, but you've got to deal with what's in front of you. If you have a wide nose in a patient who does not require significant hump reduction, you will have to take measures to narrow the upper vault. If you have a patient who has, you know, who has a hump and you're going to reduce it, you know, the humps are always narrowest at their apex. And then, you know, when we do a hump reduction, we end up with a wider nose, and then we infracture to set the width of the nose. So with a hump reduction, using a Joseph technique, then we would use any sequence of osteotomies so that we can just control the width of the nose through that infracture of in whatever way we want. I don't see how you'd be able to control that width if you're doing a preservation. You get what you started with. And so that's kind of my issue. It doesn't mean that it's not a good technique for the right patients. And this is where I go back to what Jay said. I think if you pick the right ones and in your own hands, it's a tool in your toolbox.
Which is exactly what I like to say, tool in the toolbox. It's not the only way. And if you only have a hammer, then everything looks like a nail. So you should have more than one tool. One question that's come up here is, let me see here. Yeah, so, you know, people talk about thin skin, thick skin. I guess we'll get to that in a little bit. I want to keep moving on here. So let's have Dr. Jeff Marcus, who comes to us from North Carolina, Duke University. He's the Chief of Plastic Surgery. Jeff, it's nice to have you, and I'll turn it over to you now.
Thanks, Sam. Can you let me know when you see my screen?
Yep, we can see it.
All right, great. Well, yeah, thank you for the opportunity to speak. Sam, you and I have gone back so many years, have good friends on the panel. Audience can try to decide by looking at the pictures whether Ben Marcus and I are related. But my talk is going to be on mid-vault repair with spreader flaps in particular, is what Dr. Most had asked me to do after a component dorsal reduction. I do want to give a shout out to Yash Avashia, who was my resident here at Duke for many years and who's now on faculty at the Dallas Plastic Surgery Institute with Rod Rourke and others. I don't have any disclosures that are relevant to the presentation in particular. And I'll echo also just what Dr. Calvert said, that the patients in this broadcast have given consent for educational use. There is risk to any individual who would copy and reproduce those images in some way. You know, we're talking a little bit about, you know, last week preservation was the technique, and Yves Saban had presented this along with Roland Daniel and his co-authors. And Roland had said at the time, this was a few years ago when we were in Paris, and he said, I think this push down and technique is going to revolutionize rhinoplasty. And it was truly amazing what they were doing. And I was listening with great attention at the time. And among the comments that this is from the Dr. Saban's paper, after dorsal height reduction, the keystone is destroyed, and then it has to be reconstructed for aesthetic and functional reasons. So that's the one thing to keep in mind. Preservation, the idea is that you're trying to avoiding the need to reconstruct something by not deconstructing it in the first place. Therefore, you're taking away, you know, some of the variability that can occur in that reconstructive phase. Makes sense. I believe that the philosophy of preservation, it doesn't only apply to the dorsum, by the way. There are other things that can and should be preserved for the same reason, to avoid the problems that the reconstruction and the deconstruction would cause. There are reasons for it. He went on to say, it's in our opinion that if pre-existing nasal dorsum can be kept intact, then it's possible to preserve that natural aesthetic dorsum as well as nasal function. Okay, so long as you like the natural aesthetic dorsum that the patient starts with, and so long as you truly have preserved function. And then in addition, he says, one can avoid many of the secondary deformities that lead to revisional surgery. And I think that gets to, you know, again, the concept, conceptually what preservation means. And I agree with these things. And I am trying to figure out how I'm going to apply the concepts in my patients. But remember, not all dorsal humps are alike. And every technique can be added to your toolbox. Preservation could be added to my toolbox. It probably will, once I understand what I think the proper patients are. But the technique that I want to rely on most of the time, just as a general philosophy, I really feel like it has to be adaptable to a wide range of situations. The most useful technique is something that you could use across the board if you had to. But the bottom line too is this, is that every surgeon really has to choose her or his complications. What things are you going to be comfortable in dealing with? And ultimately, I think that's what will probably lead me into, you know, my use of preservation in the future or not. But in the meantime, I very much like to do a component reduction. I do it a little bit differently than Ben Marcus, although this was from a few years ago, so he may be doing it different now too. But I typically take it down truly in components. I've released the upper lateral cartilages from the dorsal aspect of the septum. I've got a broken off 11 blade there, with which I'm going to be taking down that component of the, you know, this is the septal component of the hump. And you'll notice that what we're left with here is that we have excess upper lateral cartilage on each side, right? So the question is, what are you going to do with that, that excess? So in an incremental approach, like I was demonstrating, and you know, I've taken down the mucoperichondrium on one side and I've taken it down on the opposite side, only in so much so that I can remove this portion of the dorsal aspect of the septum that applies to the hump, right? But once I've done that, there's going to be this excess upper lateral cartilage. So like I said before, the question arises, what do you do with it? Well, option one is you could resect the excess upper lateral cartilage. So we take down that dorsal aspect of the septum, again, using the straight blade, and then we're taking, in this instance, using scissors, and I'm taking off the excess. So what I'm probably going to be doing here now is I'll probably either be doing a direct repair, if I feel that's the right thing to control the width of the mid-vault, or I might be using spreader grafts. Those would be my options based on what I feel needs to be done functionally and for the control of the mid-vault. But there, fortunately, there are other options as well, which came up in the mid to late 90s, the use of spreader flaps, which are also sometimes called auto spreaders. Larry Berkowitz, who you see on the bottom left, and Ron Gruber, also a Stanford guy, on the top right, along with Jack Gunner and Rod Rourke, both described this technique, and it's a very valuable one. And I'll just show you basically my, I guess my approach to using spreader flaps. You notice that the dorsal aspect of the septum has been taken down and I have this excess. I personally like to take the mucosa down off of the undersurface of the upper lateral cartilage because I don't see the need to really have the mucosa all folded in. So I've teased it down off of it. Now I'm doing a horizontal mattress suture. In this case here, I'm starting at the top. I have a hemostat on each side, keeping traction on the caudal edge of the upper lateral cartilages, and I'm working my way down. This isn't the only way you do it. In fact, I do it other ways too. Sometimes I'll set the bottom suture first and then work my way up. And then the cartilages are folded under. Notice that the cartilages in this case are relatively firm. These are fairly solid constructs. That is not always the case. So if I have firm cartilages like this, I have to make sure that I get the width correct and that the spring of the cartilages itself will not keep the mid-vault wider than I want. So when you have thick supportive upper lateral cartilages, you have to give that some thought. You'll see in a slide that's coming up, Dr. Most, on some occasions at least, will make an incision in the upper lateral cartilages in order to control that mid-vault width. So again, I've put a series of sutures coming down the mid-vault and I'm setting the width the way I want. So that's the control. Dr. Calvert said, I want control, I want precision. And I think that this affords me the opportunity to do that. I don't have to take what the patient has come in with. Looking at this patient, she has a lot of different problems here. So she does have a hump, and it's an asymmetric hump. She has angulation, she's got flare, she's got a broad keystone. I don't know, I'm not sure how one would apply a preservation approach in this kind of situation. But fortunately, a component dorsal reduction approach with reconstruction is adaptable and it can manage this exact situation with fairly good ease. And so here she is, excuse me, at about a year later. And you notice we've controlled the dorsum, we've controlled the width of the upper vault, we've controlled the width of the middle vault, we've put the tip in proper relation, and she ends up with a fairly good result from that. A nice straight profile, and then in the 3/4 view, and then finally from below. So spreader flaps are a technique that are in my toolbox. I talk about having the top shelf of the toolbox and you have the bottom of the box. The top shelf of the toolbox is all the tools that you use the most often. The bottom bin of the toolbox are things that you might pull out every now and then. And for me, spreader flaps are in the top shelf. So a component dorsal hump reduction to me is, it's a prerequisite to the mid-vault repair, of course. And the keys there are preserving the mucosal lining, preserving the upper lateral cartilages. In other words, we're not going to resect them. We want to be very careful to preserve them, because depending on how much of them you have, you want them to be able to fold over so that you can reconstruct. And then also this preservation of the keystone area. I want to make a real point on this, is that if we've reduced the dorsum, we've done a dorsal hump reduction, and here we are in the keystone, these attachments where you see my pointer, these attachments of the upper lateral cartilage to the nasal bones are important. You do not want to release these anywhere beyond where you did the resection. So you've preserved all of this upper lateral cartilage here, and you've left them attached. And the questions I've seen in the chat about avoiding irregularities and things, this is one of the main things you might see as a problem in a Joseph reduction with flaps or grafts, is if you have released those upper laterals too much, and that way they basically can fall in. So we did some work as far as looking at decision making, and this was published, I guess, this month in PRS. And we had an expert group that looked at, I won't take you all through this entire thing, but we had an expert panel that looked at a large series of patients. I think Dr. Most was on that as well. And we looked at pre and intraoperative analyses and how that affected the decision making for the technique. And I'll summarize it just to say this, is that there's basically 3 ways to repair the mid-vault. You can directly repair things, like I mentioned before, just put the upper lats back together with the dorsal aspect of the septum. You can do spreader flaps, and you can do spreader graft. And according to the panelists in this group, these were the things that affected their decision-making process the most. One was the nasal bone length. One was the quality of the upper lateral cartilages. In other words, are they of good stiff quality? One is the size of the dorsal hump, small hump versus big hump. The main thing there being, if you have a large hump, you can do spreader flaps. If you don't have a large hump, you may not have enough cartilage to do spreader flaps, and you may be forced to consider one of the other 2 options. And then the last being internal valve collapse and or septal angulation, in which case most of the panelists, for a variety of instances, whenever these were present, there was a greater tendency for this group of experts to choose spreader grafts rather than spreader flaps. So who is the best kind of candidate for spreader flap technique? The most well-suited for using spreader flaps are the ones that are going to have a fairly large hump reduction, so they'll have excess upper lateral cartilage, and the dorsum is relatively straight. It does not mean that you cannot use the spreader flap technique for other things. So for example, in long nasal bones versus short nasal bones, long nasal bones are going to be more well-supportive, right? Short nasal bones are going to be less well-supportive. But you can do spreader flaps on patients with short nasal bones as long as the upper lateral cartilages have relatively strong quality. Does that make sense? I hope. In long nasal bones, you have a lot more leeway on anything. I mentioned that the hump size has to be greater than 2 millimeters, and then internal valve collapse. Again, most of the surgeons in this study favored spreader grafts, but spreader flaps can be adapted even in situations of internal valve collapse, particularly if you use sort of spanning sutures over the top to sort of bring the upper lats up and hold them in position. And that raises the question about what is the functional capability of spreader flaps? Do they confer any functional advantage at all? I will just show this and won't go into too much detail. I just wanted to acknowledge Dr. Most, who also really had a terrific paper looking at the utilization of the spreader flap technique and which patients he felt were most applicable. And there are some differences here, but like I said, I think that there is a lot of adaptability, and there's some judgment that goes into how you adapt things. I'll show this case example, and then we'll get back to this functional question. This is a 31-year-old, and she has both functional and cosmetic issues. My practice, I think, is probably out like Ben Marcus's, where I get a lot of the combined rhinoplasties. She's got a moderate dorsal hump. She's got long nasal bones, weak upper lateral cartilages. Her septum is angulated, and she has some caudal septal tilt. And we did a mid-vault repair after Joseph hump reduction using bilateral spreader flaps. And this is her result, and this is at about 18 months. Smooth dorsum, fairly good dorsal aesthetic lines, tip in good position. There's a slight residual bump there that I see, which fortunately she does not mind. But that would be, I guess that would be a technical issue on me, and this is her from below. So getting back to the question, do spreader grafts improve function? So Dr. Most and you in archives in 2011 used the nose questionnaire, later became the schnoz, And they found that spreader flaps did confer mild improvement in cosmetic patients. And they also demonstrated that it showed significant improvement in these functional patients. Now that's interesting. That hasn't been always the case as far as other studies. There's been some conflicting data. And if you looked at this at SADE in 2014, this is with acoustic rhinometry. So again, this is not a subjective analysis, but purely objective, only looking at cross-sectional area. So we don't know how that applies to how they feel it. But in acoustic rhinometry, demonstrating that there's no improvement in with spreader flaps. So there is a little bit of conflicting data on this, and so it has not been totally clear. Some number of years ago, my group looked at a cadaveric model for analyzing the physiologic and anatomic consequences of spreader grafts. And so we did this mostly using, it was rhinomanometry, acoustic rhinometry, et cetera. And then we took that type of an approach, that cadaveric model, but instead, in looking at do spreader flaps improve function, we used a little bit more robust technical advance called computational fluid dynamics. CFD has been used by a number of rhinologists and rhinoplasty surgeons. My former colleague here in the area was Julia Kimball, who was at UNC. Dennis Franchito, my colleague now in otolaryngology here at Duke, who trained with her. I give her credit for getting us involved. We started to look at a number of different patients, and we used that same cadaveric model to describe the physiologic change after hump reduction and mid-vault repair with spreader flaps. And we wanted to see in particular, what's the difference between spreader grafts and spreader flaps? So we took a series of specimens. These are 5 cadaveric specimens, and we obtained only specimens who had significant dorsal nasal humps. By the way, that's not an easy thing to do. So we did have these 5 specimens, and the idea here was that we would do a component reduction technique, but we left the osseous component intact, did nothing with the osseous component because we didn't want it to be an additional variable. We only wanted to see what the effect of the mid-vault reconstruction technique would have on airflow and fluid dynamics. And the technique that we use basically for spreader flaps, this was from the actual study. This is one of the cadavers, taking the mucosa down. We're going to be placing this needle in, and we're going to work now from bottom up. Same thing, folding under and working our way again from bottom up to put the mid-vault back together. So just wanted to show briefly, just from that this is from the actual study, this is what we did. And then finally, all the way down to the caudal-most aspect. So what we found was, looking at a control group who had the control group was one that had just the hump reduction, then spreader grafts and spreader flaps. The red asterisks are your spreader flaps. And you look here that the average resistance ratio, so what that is the more obstructed side, because everybody always has a more obstructed side, the more obstructed side over the combined resistance of or the total, and then looking at what the resistance ratio reduction was about the same for spreader grafts and spreader flaps in that group. And then we looked at unilateral flow. So if you look strictly at flow on the more obstructed side, with spreader grafts, there was a 65% increase in flow, and spreader flaps had a 43% increase in flow. I'll say that there's a limitation here because these studies to get a significant N is extremely difficult because each specimen to do CFD on takes an extraordinary amount of time. And so to collect enough data to actually to get to a point where we could do a more robust statistical analysis is pretty challenging. But what I can say from this is that it's clear that spreader flaps do not have a negative effect. They appear to confer a positive effect, but we cannot say for sure how much of a positive effect it is relative to spreader grafts. There's some of our data suggests that they are equivalent. I want you to look at this as our last slide, and this is the control group. Notice the flow void that occurs that is present at the internal nasal valve. I think you can probably see my cursor. This is this tells the whole story. Look at what kind of flow you've established after spreader grafts. Now compare the control to spreader flaps. It's very clear that there is flow through the internal valve region after either one of those techniques. So in summary, component reduction with the mid-vault reconstruction to me remains a pretty adaptable approach to reductive rhinoplasty. Spreader flaps do offer certain aesthetic advantages, and the technique can be adapted to a wide variety of circumstances. And based on this information here, I believe that spreader flaps do appear to have some functional benefit at a level that's similar to spreader grafts, but with an exact magnitude that's yet to be determine. And I thank you for your attention.
Thank you very much, Jeff. That's really great, and you know, I really respect and appreciate the approach you're taking to this problem of mid-vol reconstruction and looking at it both from a clinical decision-making point of view and also scientifically at what exactly is going on. I'll just say one thing, that paper that you cited from 2011 with spreader flaps, we had two groups of patients. One were just purely cosmetic patients with normal nose scores, and we basically showed that they were unaffected, which was one part of the study that we wanted to show at least they're capable, that spreader flaps seem to be capable of preserving the nasal airway, at least subjectively. And the other ones were functional patients who came in with a high nose score, and we did all sorts of functional things to them. So the point wasn't that necessarily spreader grafts are improving their airway. There were certainly other things done that were confounding. So just want to make sure that that's clear. I want to show one, I'm going to ask you that same question about a difficult problem. So think about that for a second, but I want to show you this. Let's see here. Can you guys see this?
Yep.
So this was pointed out to me a few years ago. This shows that what is new has probably been described previously. And this is Samuel Fomon, who of course is a famous anatomist and did most of his work in the nose, worked with Caudle a bit too, talked about spreader flaps in 1950 in Archives of Otolaryngology. I'm not saying the people in the 90s at Berkowitz and all those guys saw this, but their work was very original and very important. But it's interesting to me that this kind of stuff is out there. So just kind of a fun fact.
Screenshot was already taken. Sorry.
I'll send that to you. I'll send anybody who wants that. It's a cool. I put that together. I took the paper title and put the figure underneath it so we could all share it. I'll send it to you. But so what do you find is one of the most vexing, difficult problems? And you're not allowed to use the same answers that me and Jay and Ben gave.
Come on, man.
That's fine. You can pick whatever you want. Is it the same problem? How do you approach it?
No, it's not. No, it's not. It's actually it has to do with irregularities. So the one thing that makes me want to really kind of contemplate the preservation is that in preservation there's very low likelihood of getting dorsal irregularities and keystone irregularities and stuff like that. So if you're doing a Joseph reduction, you have to get that reconstruction correct. And I mentioned, you heard me say about taking down the upper lateral cartilage off the nasal bones. How do you think I came up with that? It's because I did it wrong, some number of times and ended up with some keystone irregularities. So having irregularities on the dorsum, and it could be just also where the junction of bone and cartilage, because in any of these Joseph reductions, you've taken that apart, and so you can have a palpable, even if not visible, palpable irregularities. And you hear a lot of our colleagues talking about using fine dice cartilage, even in all patients. Enrico doing that, and Wolfgang, I think, just to camouflage dorsal irregularities. So I would say probably, in my estimation, I think everybody who does a reductive rhinoplasty using a Joseph technique has to have some set of tools in their box to avoid having irregularities. Yeah,
so that is probably number 2 on my list for one of the most difficult problems. In fact, one of the questions from the audience is, when reconstructing the K area after reducing a hump and placing spreader grafts, how do you make sure there will not be a small step off over the years, which is really the same thing you're saying. I think that one of the things about the dorsum is that it has a slight curve to it. The midpoint is the highest point, and we end up with something a little flatter, and the skin is thinnest in that area also. So the teaching has been in the past with these to leave a very slight curve there, and a little bit of a central height. You leave that behind so that you preserve that. But as you know, when you take these down, you can end up with a little discrepancy. Now, one thing that I do when I do this is, I used to do what you do, which is cut the cartilage of the septum and then take an osteotome, or preferably a rasp. And I stopped doing that because what I do now is take down the bony cap with a rasp, and then you can even eggshell the bone there, and then just take that off, and then gently release the upper lateral cartilages underneath that area. So the upper lateral cartilages, as you know, extend up beneath the hump, and then use those as part of your spreaders and try to keep that. But that's just one of those tricks. I still end up with irregularities. You have to put little grafts up there, fascia, chopped cartilage, whatever.
Yeah, Sam, that's a really good point. I didn't mention it, but I saw Nuri Çelik, who's a great Turkish surgeon, some number of years ago, and he was talking about taking the bony cap down first before taking down the cartilages. And I shifted to that completely, probably maybe it was about 3 or 4 years ago. And whether it's using piezo or using often a diamond burr, I think taking that bony cap off, because you can take it right off the cartilage and you preserve all of that good upper lateral cartilage that's under the cap. That's game changer.
Right. Yeah, absolutely. I agree. Ben, I think you had a question.
Yeah, I have a question for Jeff. So I certainly have used auto spreaders, thought your talk was great. But one of the things that's prevented me from implementing them in, say, every primary hump takedown is I find that the reconstruction of extended spreader grafts to the tip supporting mechanism, and especially a caudal septal extension graft, is so powerful. And when you're using the spreader flaps, not as doable. I wonder if you could comment on if you think that that particular type of reconstruction is valuable and how you balance that out when you're doing your spreader flaps.
This one I might have a hard time kind of getting it all together, because we all have our preferences about our tip supporting mechanism. How are we going to do that? And my own method is something I'm writing up now, and Sam is publishing in Clinics and Facial Plastics, and I'm talking about ligamentous preservation. So preservation of the ligaments between the medial crurae, the interdomal and intercrural ligaments, and then a resuspension of those ligaments on the caudal septum with or without a septal extension graft. And so my method, which may be flawed because maybe it might not be as strong and rigid 10 years down the line as what you're doing, I don't know that yet. My method does not rely on having extended spreaders to the support mechanism. So if I'm right about this, then it won't make a difference in the long run. But it's just a matter of we're choosing our picking the poison, I guess.
I'm going to just put one more question out there. This is for all the panelists that came up, and it's something that Jeff and I just mentioned. So everyone can answer this if they want. How often do you use cartilage paste or anything else really to camouflage irregularities? And I would say for me, when I do dorsal hump, I don't know what the percentage is, but if there's any concern about it, I will use something to make sure that dorsum, especially at the key area, is nice and smooth and has no irregularities. I don't know what the frequency is, but let's just say as often as necessary. And I sometimes use crushed cartilage. Sometimes I use very morselized cartilage, very thin. You have to make sure it's very fine, because that skin is going to thin out a lot as the swelling goes down, and what you may think is smooth won't be in about a year. But for all the panelists, if you have a quick answer for that, that'd be great.
I think it depends on the patients you have. Thin skin patients, I have a lot of thin skin patients, so I use cartilage paste. I also use this derms we have in England called permacool. It's a porcine derms, which is like a derm. So I would say maybe 1 in 5. So it's quite high actually.
I try not to leave dorsal irregularity. So I very rarely will use any kind of camouflage. I really spend a lot of time making it as smooth as possible. If I need something, then I like to use either some crushed cartilage, or if it's really something that I see, I'm going to get a piece of deep temporalis fascia.
Mm-hmm. Pietro?
I'm not embarrassed to say I use it all the time. I mean, I just don't want to take any chances, and I think that again, I just see very little downside to it. If I always try to preserve a little bit of extra cartilage, make a little bit of paste, and even putting a thin layer on there has, I think, saved my bacon a lot of times.
Well, I've seen that every irregularity I see, it is always a technical mistake. So we have really, this is not a guesswork. So I think that we have really to be very, very, let's say, careful in making it. And I use cartilage paste in about one third of my of the cases I do. So this is pretty often, but I will show it in my presentation.
Okay.
Sam, there was one of the question also asked about the width of the graft. I'm just do you mind if I just share screen real quick?
Go ahead.
Okay. All right, do you see that?
Yes.
So I think that the person who asked the question was wondering if the grafts are the same, what width they are above and below. And so This is how I basically do it, because all septal cartilage is, has variable width. So I do try to put the wider portion of it down at the valve region where it's not even going to be visible. So you're not going to get widening of the mid-vault by having the wider part of it at that lower aspect. I just wanted to share that.
Yeah, that's great. Okay, so let's move on. I'm going to next turn over the Zoom screen to Dr. Hesham Saleh, who comes to us from the UK. Thank you so much for joining us, and I look forward to hearing what you have to say.
Thank you very much, Sam. I'm gonna share now. Do you all see my screen?
Yes.
Great. So thank you so much for Dr. Samos for inviting me to this really nice webinar to show one of my favorite techniques. We've been hearing a lot about preservation. I'm really happy that we are talking about the Joseph techniques. This is my hospital, University Hospital Charing Cross in London by the river there, in a nice day like today. Now the slide decided not to move. I'm just gonna, yeah. So I have no disclosures. I put this just in case not to take pictures of patient, but they have signed for the webinar, but it's nice not to distribute them if possible. Now we talk about Joseph, so I thought I'd show my proudly my edition of Joseph original book 1931, which he showed all his techniques. That was given to me by the late Tony Bull. And you could see in lots of diagrams in his book how he showed the hump reduction and his technique using that saw on the left up there, and various types of humps, including some of these dorsal deviations here. What we do is probably similar, but there are lots of variations, and the technique lives with the same time as the preservation. Personally, I do, most of the time, I do a Joseph technique, and I very rarely use the preservation, which I tried a few times, but I've been doing this for 20 years. So I think it's maybe a bit too late for me, but I am trying it. So my rhinoplasties as well are mostly endonasal, 70% endonasal. That's the way I started with, that's the way I'm comfortable with, but I still do 30% open, not necessarily secondary rhinoplasty, but also the primary rhinoplasties. And these are the techniques I use for the dorsal hump reduction, that I call it an in-block hump reduction, which is through the endonasal technique, and the split hump technique. And I'll show the differences. So when do I do the endonasal hump technique or in-block hump reduction? Is for moderate humps. I roughly arbitrarily put 3 to 6 millimeters, not quite as precise as this, and it depends on all other judgments that I decide on the assessment of the patient in other regions. But one of the important things is to avoid this in patients with short nasal bones and weak upper lateral cartilage when I'll use the other technique. So this is what I do in these patients. I'd use through that endonasal technique, the 15 blade. I start my resection of the dorsal cartilaginous hump at the osteocartilaginous junction and toward the anterior septal angle there, and then I'll leave it attached, and then I'll do the number 2, which is following it from there, from the osteocartilaginous junction to the radix there. And then that's one component which I'll remove. Important thing is that I decide prior to the rhinoplasty if the hump is small enough or medium enough for me not to detach the upper laterals completely from the septum, so I'm preserving without destroying this area. If I'm suspecting I'm destroying this area, I'll have to consider another technique. So this is one patient through the endonasal technique. This is my 15 blade cutting through into the cartilaginous hump toward the anterior septal angle. Follow it here with the Gilbert nose trinity osteotome, and then removing the hump in one piece. So if this hump is large or the patient has short nasal bones, I would consider the other techniques that have been shown already by my colleagues here today, which is the split hump technique and the autospreaders or spreader grafts. So when I see a hump that's quite large, or the patient has short nasal bones, weak upper lateral cartilage, plus other assessments I'd consider on every individual patient, I'd use this technique. And I started using autospreader grafts a few years ago. In the past, I always did spreader grafts, but I still have different indications for either of them. So I use the autospreaders for reasonable length nasal bone, upper lateral cartilage and septum. I'd use the spreaders when the upper lateral cartilage are weak or the patient has short nasal bones. But I like the spreader graft and the autospreaders technique in variations, but we've talked about them a lot today. Then I'd consider the osteotomies after I've removed that hump. So the way I'm used to and the way I do my osteotomies are the percutaneous osteotomies, which I've done over the years, without almost never doing endonasal osteotomies, except when I have a patient with very thick nasal bones, which is quite rare that I actually need to do. The way I do my endonasal osteotomies, or the lateral osteotomies, is low to low. I preserve the Webster triangle. I go low to low, and I have two components. I have the horizontal component and the transverse component. So I can get this part of the nasal bone and the maxillary process to mobilize. So I always have the transverse component at the level of the medial canthus. If I have a patient with twisted nasal bones or convexity or concavity, I use a different thing from a lot of people, which is the mid-transverse osteotomy. This is what I call them. They are transverse as well, but they are at the level of the maximum convexity or concavity, and they're done percutaneously as well, just prior to the lateral osteotomies. And just to show an example, here's a patient with very convex nasal bones. They are wide as well, like we talked about earlier. So I plan my transverse osteotomies beforehand, and I do it through, this is a different patient, through the skin, the percutaneous. So start with this. So you create two parts of that bony deviation here, and then you do the lateral osteotomy. And again, as shown here, I have not done a medial osteotomy because the hump removal constitutes a medial osteotomy in itself, which is the open groove. And this is patient with twisted nose, convexity, concavity, and straighten it after these transverse osteotomies and lateral osteotomies. So I would like to show a patient now, which shows the in-block technique, because particularly I wanted to show this, which is slightly different from what we've been seeing today as well. So she has a bit of deviated nose. It's not severe, but she has some deviation that concerned her because she had trauma before. She has a deviated septum and function problem as well, with obstruction toward the left side. But also, if you look at her lateral views, you will see the deviation and the hump in a minute. But here's the deviation of the nasal bones and a bit of the septum there. And that's the lateral view. So she has a moderately large hump, quite a prominent spine with muscle is, or the precipice muscle is quite strong as well, some overprojection, and she wanted to reduce this nose, plus improving the function problem. She's only 19. Now we have the two options here. Would you consider an open approach with autospreaders, or would you consider in-block? And it's something I have to judge on my assessment to the patient. She has quite long nasal bones that go to here. This is short and strong. It's probably not going to collapse. And if I'm able to remove the cartilaginous hump without separating the upper laterals from the septum, preserving this valve, I would do the endonasal approach. And that's what I've done in her. So that was my plan here prior to the surgery, is to do an endonasal rhinoplasty with in-block dehumping technique and lateral osteotomies, plus delivery of the tip, which we're not going to talk about much, and tongue and groove technique. Here's the video, which shows the beginning of the surgery. I've already opened, I've done already my intercartilaginous incisions. So I am using my 15 blade here from the osteocartilaginous junction toward the anterior septal angle to reduce that cartilaginous part of the hump. And then I'll leave it there, and I will use my osteotome in a minute to follow that hump. So I've preserved the attachment of the upper laterals to the septum, so they're not detached. So here I have put that osteotome in, and I've removed the hump. We'll see in a second. Obviously, the edit is edited here. You see it's this residual height here. So I'll leave this until I've done my osteotomies to the percutaneous route or approach. Lateral osteotomies only, no need for medial osteotomies. And interestingly, I've seen a study from Sam shows less edema with this than the endonasal. So after mobilizing, so we'll mobilize the nasal bones, and then I will check there's still a bit of height. And this seems to be more of a cartilaginous height. It's very minimal, it's a couple of millimeters. And we just mentioned Samuel Fomont, and this is a scissors. I'm using them to remove a sliver of this dorsal septum to complete my dehumping. After that, I'll make sure there's no irregularities. So it's a sliver, I'll take it out now. We talked about irregularities. I make sure I use very fine rasping to make sure there's nothing left. We check and check and check. But if a patient had thin bone, I will still, thin skin, I'll still put some soft tissue grafting or cartilage based. So that was the case done, and then see the patient later on. So that's follow-up. It's 11 months, and we could see the frontal view with the straightness of the dorsum heel and the tip we're not going to talk about, and she has a smile. She's happier. She can breathe better as well because we've done a septoplasty at the same time. You see that slight twisting here and it's straighter on the left. And from the top view, you can see as well the straightening of that dorsum, and the quarter view, and the lateral view, and the other quarter view, and the lateral view. So that's really what I wanted to show in this particular technique for hump reduction without using any grafting and maintaining the valve in a patient like this one. So thank you very much. And I just want to remind you that we have an online virtual meeting for the European Academy on the 18th, 19th, and 20th of September. And that's a meeting with 4 parallel sessions and 100 talks. New experiment, and I think it will work well. But this is the world we're living in now. Thank you so much.
Thank you. Thank you very much, Hesham. It's going to be interesting to see how this meeting goes. Actually, I was going to ask you a question about that, but that's going to be interesting to see. So that's going to be all day for a few days, the whole meeting virtual?
Yeah, 2 days, 4 parallel sessions. They all recorded. So obviously the attendees, they'll be watching sessions that they like. But because it's all recorded, it will be available online afterwards to be watched as well in the European Academy website.
That's great. I just want to make sure I understand what you did there. It was a very interesting case and very nice results. So you don't release the upper lateral cartilages from the septum, is that correct?
Yeah.
But you cut a portion of the septum out
on the top,
and then you did the dorsal reduction. So the upper lateral cartilages are still continuous up above?
Still continuous.
And then they fall into position?
Well, they don't drop unless you completely separate them from the septum. If
right.
I feel so, in patients who are not sure about, you're asking about the difficulty on hump reductions. There are some patients in between. I'm not sure of the size of the hump. Is it going to split or not? So then I will consent them that I may have to open the nose and do spreaders or auto spreaders. So that's my limit here.
But,
so
but the arch is essentially intact of the upper lats.
Yeah.
And it just sort of, okay, that's very interesting. I'm not sure that I've seen that before. That's very interesting. And what do you find is the biggest challenge for you when you're doing these sorts of hump reductions, or what was and how have you solved it?
You said that we shouldn't repeat, but it is actually.
No, that's fine. No, it's fine. I was just kidding. Yeah, that's fine.
The motivation of the septum, it always is. And it's hard and have to try various techniques. And I have, very rarely, I've had to do an extracorporeal septal rhinoplasty in some of these patients.
Yeah.
It's just a small part of them. But it is the septal deviation on the dorsum. We have to open the nose, separate everything, use various spreader grafts, not auto spreaders, and try to straighten the septal dorsal deviation itself. The second one is the irregularities, like we talked about. I try my best to make sure that all irregularities have gone, but I use the soft tissue grafting or cartilage paste and so on a lot, 1 in 4, 1 in 5, just to be on the safe side. Mm-hmm. Because of thin skin, because a lot of my patients have very thin skin.
Okay. Yeah, I guess in England, a lot of folks with thin skin, a lot of fair people. So one question I want to ask everyone, and this is something that I brought up, and someone wants us to kind of do a little mini poll here. How many people, when they're doing dorsal hump reductions, remove the bony cap, as I talked about and Jeff said he does, and then expose the upper lats underneath the bone before proceeding?
Well, I do the cartilage first, as I showed
you.
you.
Yeah.
When I do the split hump technique, it's the same. Yeah.
Okay. Jay and Ben, Pietro? Well, we'll see, Pietro, how you doing in just a minute, I guess. Yeah.
I do the cartilage first.
Okay.
I tend to do the bone work first and then do the cartilage.
Okay.
But there are other times if the hump is ginormous, then I'll do the cartilage first and then do the bones.
Right.
Yeah, because sometimes you can't see over top, you know.
Right. Okay. All right. I think we're going to move on now to our last speaker, Dr. Pietro Palma. Who is a wonderful friend and someone who I've known for many years. And he's going to share with us his technique for hump reduction. So thank you very much for joining us, Pietro, out there in Milan.
Can you see me, Sam?
Yes.
Excellent, thank you. So thanks, Sam, for having me here with you in this Corona webinar. There are so many now. So this is the issue. This is the issue. And of course, we have two schools of thinking, the preservationists against the dehumpers. It was 1 week ago, was the other school, and now we are here, the dehumpers. And I would like to share with you my Endonasal way of doing this. And I give the disclosure is this. So this is the starting point. Obviously, we have very different humps. Each one is different. And it is never actually just a hump removal. I like to think about contour rhinoplasty. This is one typical case. What has been changed actually? If we look at the, let's say, the landmarks on the let me put the charger here. If we look at the side view, the position of the dots is different. You will see here. And we have changed actually the position of the dorsal landmarks, the reciprocal relationships among the dorsal aesthetic subunits, and the blending of the junctional areas. So this is much more than lowering the dorsum. And in one word, I like the concept of clarity. And many times in contour rhinoplasty, it is a wise mix between additions and taking some away. So this is the case. This is the pre and post, and again, plus here, minus there, to get the clarity that we want. But be aware that when you change the dorsum, you change critical aesthetic things on the frontal view. So you change the width of the bridge, you change the width of the bony base, and you change the convexity of the lateral walls here. You see here, so when you change the dorsum, you have to change also other elements on the frontal view. Sometimes you want this, sometimes you don't want this, but be aware that you create these changes. So where to go? Which one, humpectomy or to preserve the dorsum? And for me, the choice actually is very simple. The choice is, I like to have the sniper perspective. I have to identify what I want to go, to minimize the side effects, and to keep the variables under control. In my personal experience, let's say push down and let down were really the beginning of my rhinoplasty journey. This is a book in 1996, and 80% of it was about push and let down. But there is my evolution. In my experience, it was like, as Jay said, a kind of guesswork. I could not control completely what I was doing. So I went to hump removal, and now I am to what I call the dorsal contouring. And of course, it has been a long journey. And the main point is that I want to maximize the benefits and to minimize risks. So we have seen just a few minutes ago that there are many techniques, many different techniques. And now I am, let's say, glad to share with you my way. This is, let's say, a myth that the hump removal creates inverted V deformity. I put it in different languages. This is false. This is not true. Because when we see horrible scars here, we all think that this is not a problem of the technique, but this is the problem of the individual surgeon. The same thing when we get the inverted V. This is not a problem of the technique. This is a problem of the surgeon, of the brain and the hands of the surgeon. So the core of my thinking and the core of my technique that I have developed in many years is the concept of vault protection. This is something that I have borrowed from my, let's say, early days of rhinoplasty. What I mean? 4 things. The first one is that I do a limited here below the dorsum. So I get some extra mucosa that determines a kind of mucosal stenting. This is what I do. This is a cotyle elevator. And then I just go, I will show you just a little clip.
Now, this is hemitransfixion. You go up a little bit higher. And here we are at the junction with the upper. You go here, you have to feel movement, circular movement on the other side.
Well, you don't need actually
now
to see.
Below.
This is a tactile maneuver.
Go here, till.
And then you do the same thing.
Hemitransfixion. Then I go here, the junction with the upper lateral.
Okay. And then the second thing is that I do actually the same thing that Hesham does. I think that if you do a full thickness division between the septum and the upper laterals, you create a problem. You create a problem. We create a problem. And of course, we have to solve it by putting the spreader grafts there. The third element is that I do a limited skin soft tissue elevation. And I do not do anymore any subperiosteal elevation here, because I don't want to create any danger, any risk to this area, which is the weakest part of the junction between bone and cartilage. And the fourth point is that I do this kind of 3 cartilages incision. I take the caliper, I measure, and then I enter with the number 11 knife, and then I go down, from up, down. And then I enter with my osteotomy, and then I go up. This is the typical transcartilaginous approach. This is the one I use in, let's say, in a vast number of the cases I do. This is very important to leave on the cartilage the soft tissues here, and then you go directly to expose the cartilaginous dorsum to see the white of the cartilaginous here. And then carefully you dissect the cartilage from the vestibular skin. Okay, we do not have too much time, so we go here. We dissect the dorsum. We see the white of the cartilaginous vault. And then I just follow that white till the radix. And then I dissect lateral, so to get more space. And then some cottonoids for vasoconstriction. And this is let's say, an important point. I always sharpen instruments, osteotomy, and the guarded curved osteotomy for lateral osteotomy. So here, I go back here. I report, then I start my 3 cartilaginous incision. It is important to go down because the most common mistake is to leave the anterior septal angle, which is the most frequent cause of supratip deformity. And then you start hammering. Okay, this is all. We do not have so much time. So what I have done, I have recreated the new nasion here, the new rhinion here, and the new supratip breakpoint. And I like the unblocked resection because in my hands, this is the only way to produce clarity. And when I have to do of course, almost 100% of the cases, we have to do the lateral osteotomy. I like to do this kind of unblock basal osteotomy. So I go a little bit higher than the intercanthal line. I enter into the frontal bone, and then I move in down. And when you have a deformity like this, I don't see any other ways, any other way to go from here to there by doing multiple osteotomies, you see here and there at the post-op control. And frankly speaking, I love more my both hands and my right elbow than the piezo. And for me, the percutaneous osteotomies are bailout things. When I'm not happy about my Endonasal way, I do the percutaneous ones. And actually after 7 days, you don't see them anymore. And sometimes, or let's say in a good percentage of times, you have to refine, especially when you have some depressions, chips, or I like the fluid cartilage. And this is, I will show you a little clip. This is a very nice way how to make it. Well, I go, yes, and then I put a little bit of blood, and then it becomes like a paste. Okay, this is a big hump. And you see here that the problem, one of the problem is the radix here. Look at the distance between the corneal plane and the radix here. Really a big nose. This is the pre and post. Again, we change the parameters on the frontal view. When she's smiling, the base radix view, the helicopter view, the side view, saying the letter P, smiling, 3/4, the other 3/4, side view, and 3/4 view. This is a male patient. You see that there is an obvious overprojection of the cartilage here. And you see also the strength of the muscles here. This is the pre and post, the base view, the length here, the length of the nostril openings, the base radix view again, the width of the dorsum, the width of the bony base, okay, the side view, smiling, saying the letter P, 3/4 view, and the other side view. And this is the last case, actually. This is the typical case when you have to add somewhere and to remove from other sides. You see here this humpy and bumpy part here. She didn't want any other base change. And I remember her, she told me, "Doctor, I trust you. Do what you think is good for me. This is the ideal patient, I think." Well, this is again the base view, the side view. And here I like to shade with the knife at this level, and then a little bit with the rasp at this level. And of course, here you have to use a graft. This is the other 3/4 view. Of course, the sutures, transdermal sutures here, and this kind of suture that I use that I call subdermal suture when you have a cleft in this area. This is saying the letter P, smiling, the other side view, the other 3/4 view. So the take-home message is that the profile line is your signature. This is very important. And we do not sell a service, a commodity. We sell a style, actually. You may like, you might not like, but this is my style and this is your style. The last plea is a plea for minimalism. Avoid the trap of overdoing. Thanks for your attention.
Thank you very much for that, Pietro. I always enjoy your talks, and to all my panelists, I learned so much from all of you every time, so I really appreciate it. I have the question for you too, Pietro. What is the biggest challenge you've seen in your career with dorsal hump reduction, and how do you like to treat it?
Well, actually, I have a couple of them. The first one is then when I have a high, narrow nose. So this is the case when I use a spreader. This is probably, and then the second thing is then when I have a kind of infraction, a kind of concavity. When the lateral wall is complete concave, and when you have, let's say, this regards both the bone and the cartilage. And in this case, I use both a spreader and then an onlay graft just to get smoothness.
Mm-hmm. Yeah, I think it's one of the fundamental tenets of rhinoplasty. I think it's easy to push it in. It's hard to get it to come out. So try to not avoid pushing anything in too much, because gravity is going to want to do that. So, one thing is, somebody posted something on the chat about, well, if if you're getting irregularities that you need to fix, why is it happening? What I'll say is this: having done preservation rhinoplasty and lots of these, you can get irregularities both ways. And one of the things, if you watch the preservation rhinoplasty surgeons talk, is talking about a step at the radix being something that's can happen pretty commonly, and you have to avoid, and lots of things that do avoid that. It's very analogous to avoiding irregularities at the keystone. So in those patients, they're putting grafts in up there, and I've done that before. So no technique is immune. I really liked what Pietro said, and I've thought this for a while, that when you see a revision case, you can't really necessarily blame the technique. You maybe want to avoid blaming the surgeon, but certainly something may not have been done right or didn't heal right. I don't like to blame, but I do think that preservation rhinoplasty, it can lead to all sorts of problems. Obviously, Joseph can too. We know that from Sheen pointing out inverted V deformities and spreader grafts being necessary, and we refined the technique. I think preservation rhinoplasty is being refined now, and I think it was dropped because of recurrence of the hump and all sorts of other problems that were occurring. So I think that you have to find what's comfortable for you to get good results. And what you said, Pietro, is true. I think I've developed a certain style. All of us have a little bit of a style, and patients may select us because of that. I'm just going to open it up for any comments from anybody here at the end before we finish up, because we're out of time.
May I add one more comment? One of the problems that I had in the past years with push down and let down was setting the position on the level of the nasum. For me, was really a nightmare, and it was really a guesswork. Sometimes it is low, sometimes it is high. So, and I think it is still there, because when I see the presentations of of the colleagues, I think that they have the same issue.
I think, for me, lowering the radix, really the only way I can do it is with a push down reliably. You can, if you want to take it down a few millimeters, but that's kind of the problem. If you don't want to lower it, then you've got an issue when you do this, because if it drops a little bit, you're going to have a step.
Yeah,
and your perspective is really good because you've done both. You did that and then you switched. Jay?
Yeah, I wanted to say that, for the people that are learning rhinoplasty now, that are 3, 4, 5, 7 years into their practice and doing 30 to 50 a year, these techniques are all, just as you said, tools in the toolbox, Sam. You want to sort of explore the ins and the outs of each technique, and that's best done in the cadaver lab. But really, the other way to explore this is what I do when I see a primary rhinoplasty is I plan the rhinoplasty 3 or 4 different ways, because you can do these operations so many different ways. And if you go through the exercise of planning and not necessarily doing, but you say, okay, let's plan this operation with a preservation technique and look at what's available. Let's plan it with an endonasal technique and see what's available. Let's plan it with an open technique and see what's available. If you do that exercise when you're learning, you will gain command of the diagnostic process of rhinoplasty. And that's where you win the battle in getting a great long-term result. You can't just say, I'm going to do a preservation on this one because it seems like a good idea. Go through the technical exercise, which takes time and effort. And everybody just wants to get to the operation. But I tell you, win these battles in the consultation and the planning process.
That's great advice, really great advice. And I think that's really not just good advice for beginners. We're all learning all the way through. We're always getting better and trying to get better. And that's a great thing to do. I always like to think about my cases, do the computer image planning beforehand and think about how I'm going to approach it. And it's true, when you get in there, you may need to switch gears a little bit and try something a little different, because it's not exactly how you planned once you get a look at the anatomy underneath the hood, so to speak. So
right, and if you've gone through it, then you know what those options are going to be. But right. If you say, I'm going to do this open because I do them all open, well, that's great. But people always, like, there's this huge marketing thing now around Beverly Hills of scarless rhinoplasty, which is basically endonasal. And so patients come into me and they say, would you do this one as a scarless rhinoplasty? I say, I absolutely can, but for you, that's not the best idea. The way that I can get the best result for you is to do an open.
Right.
Marketing is so powerful that it pushes a technique rather than a result. And I try to get the patients focused on results, not on how you get there. You just have to do the best thing you can for your patient, and education is really key.
Yep. I would just add that in addition to, obviously diagnostics of rhinoplasty are what allow you to pick the right technique. And then the corollary to that is just long-term follow-up. We all want to kind of get to the next operation, and we're not getting compensated to see a patient at 2 years or 3 years, but that's also where you learn. If you're honest with yourself and you look at your pictures, even if the patient is happy, but you say to yourself, what could I have done better? Is there a technique that would have worked better here? That's the other way to really make sure you continue to grow.
Absolutely. Excuse me. Does anyone else have any other comments? Well, I just want to wrap up by saying thank you to all of you, Jeff, Jay, Hesham, Ben, Pietro. Thank you so much for coming. Thank you to Sachi for organizing this once again this week, taking your Saturday morning out. And I wish you all the best. And I look forward to seeing you in person, hopefully soon at a real life meeting. So take care.